Hi, it's Dr. Centeno, and welcome in. This is Facebook Live today about an interesting topic, I think, some vagus nerve hydrodissection that we've been doing. And I do want to make sure that everything goes smoothly today. So I'm going to try to just take a minute here and go ahead and probably just log in separately to a YouTube channel just to make sure that this is happening as it should. Okay, so I'm just going to monitor it on the other side just to make sure that I can make sure that all the slides show this time, all that good stuff. So anyway, welcome in. Again, going to be talking today about vagus nerve hydrodissection. Some of the new interesting things we've been doing with that, or I've been doing with that over the last 6 months or so. Those patients are now starting to cycle back through. So I've been able to get a good sense of how that all is working out. And so far, so good. And so, as usual, we'll start with a lecture, probably only going to be 15 minutes there. Then we'll go to Q&A, whether it's about this topic or any other topic, doesn't really make a difference. So we'll get started with that. Again, I want to make sure that all of this slides show up. So trying this a different way today, going to monitor it on the other screen here. Let's figure this out here. That should be the right one. Hold on a quick second. I gotta change this to a kiosk. There we go. That should work. Okay. So vagus nerve hydrodissection using platelet growth factors. And again, this is a project I started about 6 months ago. And the concept was that we were already doing quite a lot of hydrodissection underneath the sternocleidomastoid here for patients who had superficial cervical plexus issues. You may not have heard too much about the superficial cervical plexus, but it's a big player in many patients that have headaches, have pain up in this area, have pain that goes into this ear area, who have CCI. The sternocleidomastoid gets really tight, then that starts to irritate the superficial cervical plexus. And then it kind of starts to roll downhill from there and cause problems. So we were doing already quite a bit of treatment in that area. And right there is the vagus nerve. So there was an opportunity to start treating the vagus nerve in some of our more autonomic-dominant symptom patients, meaning these were patients who had things more like anxiety, stomach issues, POTS, tachycardia. So that's how all this started. So again, now I just switched the slide here. There we go. Good. Looks like it's working. I want you to like, comment, share, and subscribe because that's an incredibly important part of what's happening here today. If you want to pay it forward in the CCI community, you want to pay it forward to POTS patients, you want to pay it forward to people that have vagus nerve issues, do me a favor, like, comment, share, subscribe, because that's how we get the algorithm to get this information out to more patients like you. Again, really important on this one. I think I'm going to spend a little time on here after all of this. There's a new site for questions on PICL, CCI, and written answers. This site is been very important. I'm on it probably at least an hour a day answering questions 7 days a week. So the site's growing now. I think when I did this, we had 76 members. Now we've got about 165 members. And I would really encourage you to go to Reddit and join this if you're interested in asking questions about CCI and you want good, honest answers from an expert in CCI, then this is the place to go. Again, I check this multiple times a day, 7 days a week. What I'm trying to do here is to build a huge amount of questions and answers around CCI, around PICL, so that patients can go to this at 3 a.m. if they want to and look up an answer to one of hundreds of questions. And I think already we're probably at around 150 questions answered. And over the next couple of months, I think we'll get to 1,000 questions and answers here about CCI, about PICL. So I'd really encourage you to go on Reddit after you're done and join our PICL. Now, that's a place where patients can come and ask me questions. This is a place where patients can go and talk amongst themselves without me involved at all. And there's a lot of value to that. Now, one of the problems I've seen, and I monitor lots of different threads online, is that there's just lots and lots of crazy stuff out there. Lots of information patients are getting that isn't medically accurate. And so this is actually a Facebook group run by patients that really take pride in trying to make sure that the information that they're giving out is accurate. And they also try to curate the whole discussion so it stays on a reasonable medical path and doesn't spin off into some craziness. So if you want information about CCI patient to patient, this is a great place to go. These are some of the references for today. As you can see, quite a few references. There's more references I'll bring up as we go. So the vagus nerve and CCI. That's really what we're going to be talking about here today. But there are vagus nerve problems out there that don't involve CCI. And that's also going to be interfacing with what we're talking about today, right? Patients who have vagus nerve issues for whatever reason. And can you treat the vagus nerve with platelet growth factors? And if so, how would you go about doing that? So vagus nerve symptoms: abdominal pain and bloating, GI issues, changes in heart rate, blood pressure, POTS, difficulty swallowing, dizziness or fainting, hoarseness, wheezing, loss of voice, GI and more GI type stuff. So basically you could break it down into cardiovascular type issues. Anxiety would be in there, as well as POTS related problems, and then GI related problems. And it's interesting because the vagus nerve is involved in so many different parts and pieces that we'll go through here, that it seems to be a very central component to health. So how is the vagus nerve related to the neck, right? Because that's one of the things we're going to talk about today. We're treating it in the neck area. Well, the vagus nerve lives right in front of the transverse process of C1. So if you've got any type of C1-2 instability, you've got the potential to bang into the vagus nerve. If you start to bang into the vagus nerve, then you can cause the vagus nerve to misfire or to become inhibited, meaning it's not working as well as it should. Now, what does the vagus nerve do from a 30,000-foot viewpoint that we would be concerned about? Well, you could call it the chill out nerve, right? Your vagus nerve gets activated at night when you sleep, and it causes you to digest your food. It causes certain immune responses. It causes your heart rate to chill out and go down. It puts you into, from fight or flight, it puts you into that restful chill out mode. Now, also note that the vagus nerve actually has another component here, right? The vagus nerve lives under the sternocleidomastoid, and it's in this carotid sheath there. And so if we have sternocleidomastoid issues, then that can also irritate the vagus nerve. Now, a lot of our craniocervical instability patients have sternocleidomastoid issues. This muscle, the sternocleidomastoid, tends to get tight when there's any issues at C1, C2. So realize that it lives right under the sternocleidomastoid, so it can be affected by the sternocleidomastoid. So let's get into, from a pathophysiology standpoint, what does the vagus nerve do? I talked about from a 30,000-foot viewpoint, it helps us chill out, if you will. But the vagus nerve gets its name because vagus means wanderer in Latin. And that's because it wanders all over the body. I would suspect that the early anatomists who started looking at this were dumbfounded by how this nerve sort of seemed to impact everything. You've got branches of the vagus nerve that actually go up into here and are implicated in headache. You've got branches of the vagus nerve that go into the lungs. You've got branches of the vagus nerve that go into the heart, into the stomach, into the liver, into the spleen, into the kidney, into your guts and your intestines. So this thing wanders all over the body, and it's involved in a lot of stuff. And in addition to impacting all of those individual organs, it also seems to have something to do through the spleen with the immune response, right? We already said that it links into the spleen here. And it's involved in repair. Remember I said that chill out mode at night was to do a lot of things, but one of the things that you do at night is repair injuries. So by activating the vagus nerve and activating the spleen, it can throw out cells from the spleen that can help to repair things. And if you irritate the vagus nerve, then the body can't do that. And if the body can't get into that repair mode, then you start to get inflammatory damage in other parts of your body. So if what we're talking about is the vagus nerve getting irritated and chronically damaged from trauma, or if it's been damaged in other ways due to illness, etc., is there a way to promote nerve repair? And is there a simple way to promote nerve repair? And what's super interesting is the answer to that question is probably yes. And what that means is that platelet growth factors can help with nerve repair. So for example, we now have a number of different studies that show that you can inject platelet-rich plasma around the carpal tunnel and around the median nerve, and it will help the nerve itself. We know from in vitro and in vivo research that platelets contain nerve growth factor, which can help in nerve repair. So we now have lab studies that seem to show that platelets can do this and the growth factors they contain. We now have animal studies that seem to show that platelets can do this. And then we also now have clinical randomized controlled trials on select nerves that show that platelet growth factors can improve nerve function in real patients with real nerve problems. So probably the two biggest players there are nerve growth factor, or NGF, and vascular endothelial growth factor, or VEGF. And one helps nerve repair, the other one helps reestablish a nerve's blood supply. Because one of the things that's not talked about a lot is that one of the problems when you get a compressive force on a nerve is each nerve has its own independent blood supply. And you're putting pressure on the blood supply, so you are reducing the blood flow to that nerve. So if you're able to rebuild the nerve supply around the nerve, then that's probably one mechanism for nerve repair. So hopefully this shows. I'm going to show you what a hydrodissection looks like. So this is a hydrodissection we did many, many years ago, probably 2012. I happened to capture a video of it. It's a carpal tunnel median nerve, but this is what a vagus nerve hydrodissection would look like. So I wanted you to see what this looks like in real time. So that's a 30 gauge needle, about the size of a toothbrush bristle, really, really small. You can see the median nerve there. The dark stuff represents the concentrated growth factors that are being injected around the nerve. For scale there, that's the size of a pea. So this is very fine work, and you can see me placing growth factors around that median nerve. It would be the same thing with the vagus nerve. And that's called interventional neurobiologics, right? Much of what we do is called interventional orthobiologics, but this would be interventional neurobiologics using autologous biologics to try to help nerves. So again, as I said, we were routinely hydrodissecting underneath the sternocleidomastoid for the superficial cervical plexus, and these are all the branches of the superficial cervical plexus. This is the sternocleidomastoid here. And so it seemed like a no-brainer to be able to say, if we just make that hydrodissection more medial, where the vagus nerve lives underneath that sternocleidomastoid, then we can try to start to see if we can help the vagus nerve function. And again, started doing that in select patients who are more autonomic dominant around 6 months ago. And so this is what it looks like here. This is the sternocleidomastoid. Now we do these more advanced vagus nerve hydrodissections now in multiple areas. This is just one area, but you can see sternocleidomastoid there. That's going to be the carotid artery. This is the internal jugular vein, and you can see the vagus nerve living between those. Now, what's really interesting is just down in here is where the stellate ganglion lives. So there's an opportunity to treat not only the vagus nerve, but the stellate ganglion as well. And you've probably heard about stellate ganglion blocks and how those can give short-term relief to patients that seem to have an overactive sympathetic nervous system, that overactive fight or flight thing going on. In the same way, we can treat that area as we're treating the vagus nerve. And again, this is just to show you here, sternocleidomastoid up here, internal jugular vein, vagus in there, carotid artery, and then right beneath that is the stellate ganglion. So as we're treating this vagus area, we're also treating that stellate ganglion area. So it's kind of a twofer as far as treatment is concerned. And then hopefully you guys can hear this. Let's see here. So this is kind of what prompted this today. Let me see if we can have that work.
Until my last PICL, which was number 4,
and then we did a vagus hydrodissection.
Hydrodissection.
Yeah.
That one. Yeah. I think it was bilateral also.
Yeah.
And like only just 1 month after that procedure, I remember one time in the middle of the night, I went to the bathroom, and when I came back to sleep, just laying down on my side, immediately I had an electric sensation on the left side of my body, went from my neck down the body, and like immediately the anxiety I have, I feel mostly in my gut. Exactly. That just instantly disappears. It's like a on-off switch, basically. So.
So that's an interesting one, because he was one of the first patients. I had 2 that week that came back that they're at that 4 or 5 month mark after their last PICL. We had done the vagus nerve hydrodissection on both of them. He had this super interesting story he relayed. The other guy also relayed that his anxiety, autonomic symptoms had dramatically been reduced after we had done that vagus hydrodissection. But this guy had a super interesting story of really describing the path of the vagus nerve all the way down into his gut. So, okay, so like, comment, share, subscribe. As I said before, if you want to pay this forward to other people who have vagus nerve problems, the best way to do that is to like what you're watching right now, because that tells the algorithm that this is important for other patients to find, and that will help those patients out. So let's get to Q&A now. Let me get to there. Before I get to Q&A, though, again, I do want to just show you this little website here. Not really a website, but this is that Reddit PICL page. And again, I mean, just go through this, all the different questions that have been posed and answered here by myself. You know, it just keeps going on and on. I post stuff here. Patients post questions here. I try to answer these several times a day. We've got little polls here going on, videos that are being posted here, etc. So again, I'd really encourage you to go on Reddit right now, and the address is rPICL, and just go here and if you are interested in getting things answered about CCI, one way is to watch these Facebook Lives. Another way is just to go on here and pose a question, and I'll answer it in writing. Sometimes I'll refer you to some videos that are out there that you might not have known about. Again, it just keeps going deeper and deeper and deeper. And this is just after only about 2 months here of content. So you can imagine how many questions and answers are going to be on this thing by the time we get to the summer. There's probably going to be 1,000 or more questions and answers here. And so let's say it's 3 a.m. and you just really want to know about something like, well, let's type in Vegas. So if we type up there, Vegas, and we hit the search, this is all the questions and answers that have been, that come back on Vegas. So you can go in here and you can jump in and get some information. So anyway, let's get to questions now, but I wanted to let people know that that was out there as a resource here. Let's start with Angelica. Can a big tongue be a problem with PICL? It's possible. We have gotten, so we're on our 3rd generation mouthpiece. We're working on the 4th generation mouthpiece right now. In fact, it's kind of interesting story. This little crazy thing here is a little caliper to start measuring some internal mouth metrics of our patients, because the 4th generation mouthpiece that we use, 3D printed mouthpiece, will make some improvements over the 3rd generation. So in order to do that, we've got to take lots and lots of real world measurements from our patients. So that's why this is sitting on my desk right now. But the answer is, I would say that probably a better question would be, how often is the tongue such a problem that you can't do the procedure? And that's probably maybe now only about 1 in 200 times. And then another question would be, how often is the tongue a struggle? And that could be maybe 1 in 20 or 30 times. Someone's got a very large tongue. And, you know, we spend more time during the procedure taming the tongue. But I think it's becoming less and less, and especially as we get to our 4th generation mouthpiece, I think it'll be a zero-sum game, because that's one of the things that we're addressing in that. We're also addressing other things remember, this is the 3rd generation design we're on now, so we're moving to the 4th generation. So a lot of work goes into all this stuff behind the scenes. Submitted advance by John, overactive bladder at night since the neck injury, which led to CCI, and a correlation between overactive bladder and CCI. Yeah, so John, one of the things I think that's a misnomer in the CCI population, and I constantly deal with, is this concept that if you have something going on with your bladder and you have CCI, then it has to be an occult tethered cord. In fact, bladder issues are a huge problem in patients with chronic back and spine problems. And I know this because we get rid of them all the time, right? Woman comes in with chronic back or pelvic pain. She's having overactive bladder issues, having frequency, urgency, etc. We do a caudal epidural with platelet growth factors, and boom, it all goes away, like it never was there. And I think the neurosurgeons that are focused on this occult tethered cord thing obviously don't have that experience. They don't do interventional work, so they don't know that you can shut these things down like that with the correct injection in the correct spot. And so what generally happens in many of our CCI patients is that the chronic neck issues then shut down the low back and pelvic stabilizers, which then can lead to sort of chronic back issues, irritation of the cervical nerves, and then that causes an overactive bladder. So if that's there, we'll just treat it with a caudal epidural around those cervical nerve roots using those same platelet growth factors. Bo, I have CCI 1A, 2B, 3A. So far, I'm finally able to hold NUCA, but still feeling symptoms. What could potentially be the next step? Yeah, so Bo, a lot will depend on what your movement-based imaging shows, right? If your movement-based imaging shows that you're stable, then it could just be going after those posterior pain generators without having to do a PICL procedure. If, on the other hand, you still had instability, despite the fact that you're holding, then it would probably be more PICL. So I think that's probably the break point there in that decision. Anja, dynamic upright MRI, is it necessary to do it in a tilted position? And what would be the benefits in addition to neutral flexion extension and left rotation? I think what you're asking here is, so what I like to see in upright MRI is flexion and extension. Rotation is almost never helpful because it's extremely rare to see excessive C1, C2 rotation on a rotational study. So rotation is not helpful. And I think what you're asking is lateral bending helpful? And the problem is that it could be, meaning I think what you're talking about here is looking for C1, C2 overhang, but the acquisition time for MRI is so long that you're not going to get the same kind of thing that you see out of a DMX study. In a DMX study, you're bending and then you're having to stop and go the other direction. That's not what we're getting out of MRI. We're getting someone bending and then the muscles cramp down and tighten up. So if someone had severe C1, C2 instability, you might see it on a lateral bending MRI. But unless it's super severe, the muscles are going to spasm and you're not going to be able to see it on an MRI. Furthermore, are there any dangers associated with upright MRI scan with suspecting CCI type 1C? Is there anything I should pay particular attention bearing this in mind? No more than the dangers in looking down or looking up, right? So if you've got symptoms with looking down, for example, then make sure that the MRI staff knows about that. The downside is there's going to be a certain amount of time that you have to stay in that position for them to get the image. And that's one of the downsides of MRI is that the acquisition time meaning the time to get the image can be quite long sometimes. Steve, are there any supplements can assist your body to heal ligaments, facet joints, or muscles after the healing process of orthobiologic injection begins? Yeah, we have a stem cell support formula that is focused on trying to reduce chronic inflammation in our patients, and also with ingredients we've tested in the lab with bone marrow mesenchymal stem cells. So that's one I could recommend. Angelica, why is it called hydrodissection? This sounds like something is cut. Yeah, so it's not really, that's a good question. It's probably not a great name. Hydro meaning fluid, and dissection meaning to break apart. So it's really a breaking apart by fluid is where that word comes from. I would agree with you. It's not a great term, but it's just kind of the term that got thrown onto it 20 years ago and it kind of stuck. Submitted in advance by John. How do you treat ocular pressure causing eye floaters? If you have type 2B CCI, will PICL sort out the eye floaters? It would be hard to make that diagnosis, John, that increased intracranial pressure is leading to eye floaters. If you're having some sort of eye phenomenon due to increased intracranial pressure, and we get rid of the CCI, which is usually the cause of the increased intracranial pressure on a sporadic basis, then the eye symptoms usually go away. As far as whether or not there are actual floaters in the eye, meaning physical pieces moving around, then this would have nothing to do with those. Lindsay, I have a problem with jugular vagus and baroreceptor compression because of my hit to my chin, top back. Gotcha, Lindsay. Some advanced by John. Is the dorsal scapular nerve entrapped because of a bulge at 5'6", or is it something else? Probably better to say that a problem with the spinal nerve at 5'6" could give issues with the dorsal scapular nerve through a double crush mechanism, meaning nerves are one continuous cell. And so it's like a garden hose. You step on one part of the garden hose, then the flow goes down. You step on another part of the garden hose, the flow goes down even more. That's called a double crush. So there certainly could be a concept of what we call sick nerves get sicker. So what I mean by that is that if you have an issue in your spinal nerve in your neck at 5'6", that's going to cause a sick nerve. Then when that nerve snakes through tight areas like the dorsal scapular nerve, then that nerve can develop other problems. That's called a double crush syndrome. Faith, any recommendations on reducing CCI progression to PICL after Botox for cervical dystonia diagnosis? Yeah, I mean, that's a tough one. As I've talked about here before, Botox generally causes some fairly severe issues in our CCI patients, right? They need that muscular tightness in order to have stability. And when that muscular tightness is taken away from them through something like Botox, all hell can break loose. And so my recommendation would probably be maybe using the collar a little bit more frequently, but just realize the more you use the collar, the more weakness you have, the more instability you're going to eventually have. And so that's why we, have been saying for years and continue to advise our CCI patients, do not get Botox because it's usually a bad day for everybody. Hannah, I'd actually, if someone needed multiple areas treated for instability, i.e. 6 areas, we'd recommend to go to Regenexx Cayman. Regenexx Cayman doesn't treat craniocervical instability and doesn't do the PICL procedure. And that's simply because the big joke in Cayman has always been, what's the best ICU on Grand Cayman? It's called Miami, meaning that Cayman is a first world island. It's a beautiful island. There's now a newer hospital there called Health City. So the island is building up its medical infrastructure, but it doesn't have the medical infrastructure of the United States, not anything close to it, as many countries wouldn't, especially small island nations. So from that standpoint, we don't offer PICL down there. We've never had to admit someone into the ICU after a PICL, but if we had to, it would be life flighting them to Miami, which makes no sense. So not offered down there, and not going to be offered down there just because the medical infrastructure, if we would need to access it, haven't had to, but if we would, is not there. SNOMAS, if injury to digastric or mylohyoid worsening CCI symptoms, can PICL still be done? Sure, yeah. I mean, we treat the strat muscles from time to time in patients that require that treatment when we're doing PICL. Lindsay, besides vagus and jugular compression in this area, is it possible to treat baroreceptor damage? I have hypersensitivity and quick changes in pressure living at high altitude. Yeah, so Lindsay, I don't know what that means, meaning that specifically where were the baroreceptors damaged? We would need to know that. And then usually baroreceptors live in vessels. So we don't do vascular type regenerative medicine work. And I don't know that that would even be all that effective. Now, what you may be describing is problems with facet joints, because the facet joints in the neck can act as little pressure sensors. And that we treat all day long and twice on Sunday. So I'm not quite sure specifically where your baroreceptors were injured. But that we would need to get to that kind of detail, not just a garden variety. I think my baroreceptors are injured, but specifically at what spot were they injured and why? Angelica, what do you think about gadgets that stimulate the vagus nerve? Yeah, it's interesting. We played with Truvaga not too long ago, probably 1-2 years ago, something like that. Maybe it was 2-3 years ago. I ordered a bunch of them, handed them out to a couple patients because I didn't know how they were going to work. Never got much great positive feedback from it. So it certainly may work in certain patients, but in our CCI patients, it didn't really seem to move the needle. I was very excited about it because I thought it might help. Like I said, I bought a couple of them, handed them out to patients, didn't charge them, just try to get some idea of would this be an effective strategy, and just didn't hear a single thing back that was positive. SNOMAS, can injuries to digastric be true with PRP? They can be, yes, either that or bone marrow concentrate. Regenexx been advanced by Harry. I recently began to get dizzy spells. That's something that is expected in CCI. Well, always, Harry, you've got to look into the other big medical issues, right? Dizzy spells can be caused by cardiac issues. Dizzy spells can be caused by TIAs or strokes. Dizzy spells can be caused by you name it. So you've got to get medically checked out. If you get medically checked out and everyone is still stumped as to why you're getting these, then yes, that can be due to craniocervical instability. Tressa, how can you get IH diagnosed without doing lumbar puncture or by a neurosurgeon? I don't feel that would be helpful at all concerning my history. CCI carry 0, bilateral superior semicircular canal dehiscence. You mentioned last week, not much point in looking at this info, but the literature says increased ICP causes holes in the tegument to grow in size. Is it worth investigating further and treating with IH with medication? Well, Tressa, the first issue is you're not going to be able to measure IH all that well with a lumbar puncture because you're at the wrong end of the body, right? IH would occur up here, increased intracranial hypertension, and a lumbar puncture is way down there. So you're not going to get a super accurate read in the kind of IIH that a CCI patient would experience. If you wanted to get that read, you're going to have to do a much bigger thing. You're going to actually need to go in and measure the intracranial pressure through a catheter that's placed up and fed up into that area. Because for most of our patients, they're getting some intermittent back pressure when they're moving their head around in certain areas. But that's usually, the lumbar puncture is not going to show up very high. When you're talking about lumbar puncture for this kind of IAH, usually talking about in babies or kids, where the distance is much smaller, and you're talking about things like hydrocephalus, where they grow a big head. So we're taking that literature and we're trying to apply it to this patient population, and it's not really an apples to apples comparison. It's a bit of an apples to oranges comparison. So if you want to measure IIH, the way to do that would be to float a catheter all the way up there. I've seen that done in some patients, but 99% of the time it's not done that way. 99% of the time it's done with a lumbar dural puncture, but that's probably not giving us real great information here. So again, if you think you've got increased intracranial pressure, and then the question is why? If the biggest why that makes the most sense is craniocervical instability, then treat the craniocervical instability. As far as taking medications for it, there isn't really an effective medication. You can dehydrate the patient, right? You can give medications that will reduce the overall fluid volume of the body, but then you're going to have other problems by being chronically dehydrated, meaning, for example, one of the Alzheimer's mechanisms they were thinking about 5 years ago was the concept that antihistamines cause that type of dehydration and drop in fluid volume, and was that leading to other long-term brain problems. So there really isn't a medication you can give somebody that doesn't then cause a whole other set and subset of long-term problems. Lindsay, would damage the vagus nerve trigger MCAS? Yeah, that's an interesting concept, Lindsay. That's one of the reasons why I threw that slide in there that talked about the interface between the vagus nerve and the immune system, because I think that's an important thing to bring up, right? That chill out nerve when we go to sleep is what allows us to repair at night. And that's the vagus nerve going through the spleen to release those immune cells. So certainly it's possible that a vagus nerve issue could lead to immune dysregulation, MCAS being along that spectrum of immune dysregulation. And that could be why we see a good number of our CCI patients with MCAS-like symptoms. The MCAS either disappears or gets much easier to tolerate and deal with once we treat the CCI. Is that through a vagus nerve mechanism? No one really knows, but this is all theoretical stuff at this point. But we certainly have observed it enough to think that that's the most likely explanation for how those two things are connected. Angelica, why is ultrasound sufficient for injection of the vagus nerve? Yeah, because what we're doing with vagus nerve is an area that's very superficial. We can see all those vessels very easily because they're right there, even in larger patients, right? Even if you have someone who has maybe double their normal body weight, you're still able to see those things. Now compare that to the internal ligaments of the spine. I can't bounce ultrasound in and out of there from the back or the front because there's bone in the way. So I need C-arm fluoroscopy for that. In the same way, I think we've talked about the concept of injecting a 0-1 and that you need digital subtraction angiography because there the artery is so small that I would never be able to tell if my needle was in that artery. Very different than here. The carotid artery and the internal jugular vein are massive compared to that little vertebral artery that goes to the back of the brain. So there's all sorts of reasons why ultrasound works here, but doesn't work there. Angelica, how to stop the SCM from depressing the vagus nerve? Yeah, so the SCM is usually chronically tight because of issues at C1, C2. And we know this because there's now a body of research that shows that when people have dislocation type injuries at C1, C2, the sternocleidomastoid freaks out. It makes sense. In fact, it's considered that dystonia within the sternocleidomastoid, or when you've got someone who has kind of a chronic wry neck, neck just is over here constantly, is due to that C1-C2 joint. That's probably its genesis. And it makes sense because 50% of your neck rotation happens at C1-C2, and the sternocleidomastoid is the primary rotator of the head on the neck. So yeah, the way to treat it is to treat C1-C2, whether that's C1-C2 damage in the joint, that would be a facet injection of orthobiologics into the joint, or whether it's C1-C2 instability. Angelica, how do you treat part of the vagus nerve that runs next to 0-1? That is part of the secret sauce, if you will, Angelica. It certainly can be done, and it certainly is a higher, a more advanced procedure to do that, but it is part of what it is we are doing. Christy, is there a specific treatment set from the PICL, or how would we know if this was treated during the PICL, and how would you decide who needs this? Yeah, Christy, so the focus, so this would be part of a PICL. It's not something that's usually separate from that, meaning it's not something we're upcharging for or anything like that. If we have an autonomic-dominant patient, and what I mean by an autonomic-dominant patient is someone, so our average CCI person in their top 3, for example, would have headaches, usually upper neck pain, dizziness and balance, usually 2 of those 3. Autonomic-dominant patients come in and they might not have any of those 3. They clearly have CCI in all the imaging. They've got a reason to have CCI due to some trauma or EDS, but their number 1 might be anxiety that started with their injury. Their number 2 could be gut issues. Their number 3 might be POTS. Their exam still looks like they've got issues in their high upper neck, but they're not having a lot of pain from the high upper neck. So those are the patients who have been getting this type of treatment with PICL because we call them, or I call them, autonomic-dominant CCI. Angelica, testimony is so interesting. All my symptoms started with cracking my neck and electrical sensation throughout my body. What could this electric shock? Yeah, so if you look at Angelica, the vagus nerve, it goes all the way from here all the way down into the gut. So what that patient seemed to be describing was the pathway of the vagus nerve I had showed you before in those slides. Joanna, I've got a heart problem now. 1/3 of the time it's making not normal double beats maybe. Can this happen because of the vagus nerve? I have CCNA caused by intubation during an IFU surgery. Never had any heart problem earlier. Well, again, the first thing, Joanna, is to obviously get checked out by cardiology. But if they are stumped as to what's causing your heart problem, then it certainly could be irritation of the vagus nerve. And that's something, obviously, we can look at and to see if all of those pieces line up, right? It's all looking at a big puzzle. I think one of the things that patients need to understand is that making a diagnosis is not about just what's on the imaging. It's not about just what's in the history. It's not about just what's on your response to treatments, et cetera. It's all of those things put together that allows us to say with either high, medium, or low confidence that you may have X problem or Y problem. But it's not any one of those things. Just because something looks like X on this imaging study doesn't mean that that's what's causing the patient's symptoms. So that's why we put all that stuff together. Tressa, can you do a vagus hydro during PICL? Yeah. Tressa, these were both PICL patients that came back last week that caused this Facebook Live. And I did a vagus hydro on both of them because they were both autonomic dominant patients. And interestingly, their autonomic symptoms were some of the things that got moved the needle on the most, right? So in order to fix that, if it's vagus nerve irritation due to instability, you got to fix the instability, which is PICL, and you've got to treat the nerve. So that's what we do. Lisa, can the vagus nerve dissection be added? Yeah, Lisa. So Again, just as I was talking to Tressa, these were both patients who had PICL, and we had added a vagus nerve hydro to those patients. Joseph, thank you, Dr. Centeno. Is the hydro part of the PICL? Yeah, it's all part of the same procedure, Joe. Very easy for us to add this in to that procedure. Lisa, not doing so well with that Reddit. Not sure what that one means, but again, the Reddit is a good way to get answers to questions. And if for some reason I'm missing your answer, by all means, ping my email, because I usually try to, like I said, I'm in there 3-4 times a day, 7 days a week, trying to keep up with all the different questions. Natasha, wow, thanks for the video. I got that electric shock that runs down the same way episodically. So many symptoms. I've lived with and stop exploring. Yeah, well, thanks, Natasha. That was an interesting discussion with that patient, right? And I'll put his full testimonial up here pretty soon. I just haven't had a chance to edit it because he did a long one, like 4 minutes, probably longer than most patients want to see. So I want to edit kind of the highlights out down to maybe 60 seconds. Or something like that. But that particular discussion was super interesting because as the doctor, it was what we were aiming for. And his description of it was eerily similar to what I would suspect patients would say if the vagus nerve suddenly woke up and started functioning. James, what do you think of the BPC 157? Yeah, James, I am not a big advocate for it. I mean, listen, if you want to try it, that's fine. The place that sells it is a little compounding place in Florida that lives behind a Big O Tires, and so it doesn't inspire confidence in me getting a pharmaceutical drug like that from that kind of setting. If you look at what BPC 157 does when it's the real stuff in real experiments, it kind of works like PRP. It's not magic at all. And so rather than buying this stuff off Facebook bootleg, meaning it's being sold illegally for research use only to patients to use clinically, I would rather just use PRP locally. It just doesn't make any sense to me. And God knows if what you're getting is BPC 157, I've got no idea. Thank you, doctor. 99% better after the first PICL, exactly 1 year ago date, celebrating my life. Well, thank you, Eden. That's wonderful to hear. It's always great to hear that stuff. Eden, if you can reach out to me, I'd love to be able to tell your story, because I think what happens for patients is, sometimes this is a big leap of faith to take, that, something like this could change their life or could help their problem. So if you could reach out to me on, whatever, I think you're on YouTube there, just reach out to me and send me a private message on YouTube. I'd be happy to try to highlight that, because that sounds like an amazing result. Angelica, can't thank you for all the time and effort you invested this topic. Huge thank you. Yeah, Angelica, thank you for recognizing. Again, like I said, I'm on this stuff 7 days a week. That includes on the Reddit channel or thread answering those questions. That includes creating video content. That includes looking at MRIs and other images for patients, obviously performing procedures, doing these Facebook Lives, etc. So it takes a lot of work. Having said that, I feel this is a real community in need, because this is a community that doesn't get a lot of easy answers to what it is that ails them. And if anything, their interactions with the traditional medical community tend to be frustrating. And so my job has been trying to reduce that frustration level as much as I can, while still trying to keep it honest, right? It's always easy to tell patients what it is they want to hear. Sometimes it's a lot harder to tell them what it is they don't want to hear, but they need to hear both of those things. Asthma. Hello, doctor. Is it possible following a false movement in hyperextension and protrusion to have a minor misalignment of the OA joint without ligaments being damaged? Sure, Asthma. I think you might want to then look at trying to see an AO or NUCA chiropractor, because their focus is going to be on that kind of misalignment. And so that sounds like a great fit for that kind of provider. Now, that provider needs to do their own assessment and see if what you've got is appropriate for them, but it certainly sounds like that might be something reasonable to pursue. Chrissy, how do you decide to do a second PICL, more imaging? What's the optimal time frame? Check back is not until 4 months. Yeah, Christy. So usually we'll look at the check back at around 3 to 4 months. Sometimes it gets scheduled at 4. But if a patient is feeling improvement before that, then we can move the checkup up. You probably have my email address, and feel free to drop me a line to let me know how you're doing. As far as the second one goes, that's based usually on what did we get from the first one? How did that patient respond? Sometimes we do repeat the imaging, but that's additional X-ray exposure. So what we try to do is to focus that on patients where we really need that to break a tie, if you will, right? The tie could be, should we do this again, or was one enough? And so that can frequently be the tiebreaker. So that's a reason to expose someone to more radiation, right? You have a clinical decision to make. Should I do this or should I do that? So that's usually when we re-image. Hannah, Dr. C, if someone had a lumbar fusion, developed instability, ASD, and other areas where they need ongoing orthobiologic injections. Yeah, I think, Hannah, what you're bringing up is adjacent segment disease due to fusion, right? You fuse an area, and then the areas above and below get more forces, and then they wear out more quickly. So yeah, when we're treating ASD, regrettably, since we can't undo the fusion and can't undo the additional forces, we're frequently bringing them back every couple of years to try to keep those segments above and below as healthy as possible. Whereas in other patients, they're not coming back with that frequency because they don't have that chronic overload. So that's why I always tell my patients, listen, there are patients that need fusion. It can be a lifesaver when it's done in the right patient where there are no other options. Having said that, it's always a dog with fleas, meaning that the fleas in this case are adjacent segment disease. So it's not an elegant solution. It may be the only solution, but if we can avoid it, we want to because of those downstream side effects. Anja, thanks for the prior answers. In contrast of any help. Is contrast of any help? Not really, not for what we're looking at, no. Asthma, and if possible, physiotherapy can help because I'm afraid of having chiropractic manipulation. Yes, and then you might want to look at something like IPA physical therapy. If you're in Europe or Australia, you may want to look at the video from, I think, 2 weeks ago, not last week, the week before that, where I interviewed Greg Johnson on a Facebook Live. If you go back to that one, he talks about the various international organizations that you can look at that are high quality physical therapists that do this kind of work. So I would really recommend that you go back in time and try to look at that video because he's got recommendations for most countries or most regions of the world about what kind of physical therapist to look for. Anja, concerning what you mentioned about bending, would getting a dynamic X-ray be a better idea from Europe? Yeah, so Anja, this is an important one, right? Because we have a lot of patients that are in this world. So let me pull that up here. And I want to make sure that everyone knows this video exists. So everyone from Europe or ex-US, because this is an important one. So if you go to Facebook, and then from Facebook, you go to my channel. So that's going to be at Centeno Home. And then you've got all this stuff up here: home, video, shorts, live, etc. If you go to the videos and you scroll it back, you're going to find this video here: how to use X-ray DDR for CCI diagnosis. So this is a whole video on how to use X-ray or dynamic digital radiography, DDR, to replace the need for DMX. So if you go online here, you can get this video, and this is actually kind of positioned between patients so that they're educated, but also for the radiology technician. So this goes through and walks them through exactly how to do all of this stuff. And it's an important one because it shows them how to set up these X-rays. So if you can get something like this done, go get that video, get something like this done, then we've got a fighting chance at being able to diagnose other types of instability outside of what can be diagnosed with an upright MRI, kind of like we do with the DMX here. So please avail yourself of that because I made that video specifically for that use case. I wanted people outside the United States to be able to try to replicate what we get here in the US with the DMX. I think we got all of that. Lindsay, what is your opinion about? Got that already. Adina, Dr. Centeno, you mentioned 2 weeks ago that threshold abnormal translation for BDI is translational BDI is 4. Is that from studies or your own observations? Yeah, Dina, that's actually a couple different places. That's 2 ways confirmed now. So if you look at Henderson's research, that's Henderson from Maryland. He's the CCI surgeon, probably my favorite one of them out there because he's very conservative. He's also published quite a bit on CCI surgery. If you look at his work, he proposes 4 millimeters as the cutoff for translational BAI. So that's BAI inflection versus BAI and extension. And he proposes it at 4 millimeters. If you then go to the Nicholson et al. Study, which is the recent study, last maybe 2-3 years, on upright MRI normals, trying to determine what those craniocervical metrics should be, they also concluded, based on normal movement patterns, meaning non-CCI patients, that 4 millimeters is the right answer. So Henderson had kind of ballparked it a little bit, but prophetically, the Nicholson study confirmed that 4 was the right answer, meaning that if you have the cutoff as 4, you're reducing those false positives, people who have that amount of motion but don't have any symptoms of CCI. So those are the 2 references for that. Joseph, thank you, Dr. C. If you perform hydrodissection, do you think? Yeah, Joe, it's just all part of the same procedure, meaning it's all done at the same time during the PICL while we have the patient lying face up, because that's the position the patient needs to be in. Lisa, would several years of Botox around the eyes and forehead in HEDS person contribute to CCI? Probably not, Lisa, but it's probably not helping. And what's super interesting there, see if I can bring this up, because I showed this to a patient the other day. Let's see. Okay, so what I'm searching here is frontalis aponeurosis. And we had a patient who kind of had a very similar question. You know, can getting, I think this was a mother who was asking for her son. Son had gotten forehead Botox, and that seemed to really make the CCI symptoms go crazy. And so this is probably why. There's a connection from this frontalis muscle up front where they would inject Botox for those wrinkles in your forehead through to the occipitals back here, and then through to probably the fascial planes that go into the suboccipital muscles. So this is all one kinetic chain, if you will. So the frontalis pulls on this aponeurosis, which pulls on the muscles back here, which pulls on the suboccipitals. So it's theoretically possible then, as I told this mother, that if you were to release the frontalis up here, that you could affect the suboccipital area back here. So it is an interesting concept and something to consider in all of this, simply because there may be a connection between getting Botox up there. Now, can it cause CCI? Probably not in the average person, but in a hypermobile person, it doesn't take much. It's really like pushing a boulder off the side of a cliff, right? The boulder rolls down the cliff naturally because of the gravity pulling it. It's a little bit like that when we're dealing with HEDS patients. I've seen HEDS patients get CCI from getting out of a cab. It's not their car. Their proprioception is a little off anyway, and they hit their head on the door getting out. I've seen HEDS patients get CCI from relatively minor falls. So in that patient population, yeah, it's probably possible. Lindsay, is the damage permanent from Botox? I don't think anybody knows. I think the manufacturers of Botox have been very, very good about trying to keep all that stuff out of the medical literature. Listen, there's a couple of things in the medical literature that would suggest that once you mess with the neuromuscular junction, it's not completely returning to normal. I don't think anyone really knows. I don't think this has been studied well. I think there's an open question as to whether or not Botox is causing permanent damage to the neuromuscular junction, and one that has yet to be answered for sure. And, you know, big pharma is powerful, boys and girls, and especially with a drug like Botox, that's a huge, huge moneymaker. You can bet that whatever is in the literature that points in that direction, they are going to try to suppress or get rid of. That's just been my experience through the years, not saying anything particular about the manufacturer of Botox, not saying anything particular about any specific manufacturer, but that's been my observation. Hannah, sorry, Dr. C, I meant multiple areas in the body like hips, low back, SI joints, ankle instability. Yeah, so Hannah, we normally treat as much as we can during a PICL procedure. If it's the first procedure, we might knock out a few of those, in that we want to see how the patient's going to respond and what they can tolerate. If it's a second procedure, we might do all of those. So I think if what you're asking is if you want culture expanded mesenchymal stem cells for those areas, you could certainly go down to Grand Cayman. But having said that, usually that's not needed in HEDS patients. Can CCI lead to surgeons? Not that I know of, but again, it can certainly lead to problems with the vagus nerve, as we talked about. Vagus nerve can also impact vasoconstriction, vasodilatation, so there may be an impact there. Rishi, I previously discussed how vital nerve compression can destroy muscles. Is the same thing for planting a nerve stimulator? Yeah, so peripheral nerve stimulation can certainly do some damage, but I think the newer stimulators probably less damage. It's not going to solve anything for anybody. It's just going to be kind of like stimulating the nerve to try to block pain signals. But I think it will do less damage than an occipital nerve decompression. Rishi, if someone want to take part of the RCT, would they possible? Yeah, so Rishi, that would only be for a native patient, meaning someone who hasn't had any PICLs before. We would then put them through all the different things that are supposed to happen there, inclusion, exclusion criteria, etc. But it would not be for a patient who had prior PICL work or anything like that, just FYI. Cassian, what do you see are time to improve vagus nerve function after CCI stabilization? Do some take year-long nerve repair like some nerves need? Yeah, that's not generally what we're seeing. We're seeing that once the patient stabilized, those symptoms tend to come on, tend to get better over the course of months. Now, I think what you're talking about is it's a very long nerve, and so could it be possible that the nerve repair could take a very long time because it's a long nerve? And I think that's a reasonable thought. Not generally what we're observing, but there certainly could be instances of neurontomesis where you've got nerve fiber disruption where that kind of repair would take much longer because of the length of the nerve. Lindsay, is it possible for extremely tight scalenes to relax after PICL treatment? Yeah, Lindsay, remember the scalenes go all the way up to the hypercervical spine. So the problem there is going to be they're going to try to stabilize. And if you stabilize the hypercervical spine, then you can get rid of that tightness. Snowmask and TMJ disc displacement be treated with PRP, BMC. Yes, we routinely treat TMJ patients when we do our PICL, and many of those have disc displacement. And we're getting towards the end, guys. I'm about 11 minutes over. I'm going to try to go through and try to pick out some super interesting questions here. Tressa, probably not helpful in treating CRPS. Let's see. Brent, is there a way to evaluate vagus nerve compression? C1, C2, is compression this level alleviated by treating CCI? Yeah, Brent. So no reason to evaluate it there. I think it's kind of wasted diagnostic resources. If there's vagus nerve symptoms, patient's got CCI, it's probably happening there. Focus is to treat the CCI. You're not going to do anything different with the diagnostic results. That's why I'm pretty critical of clinics that are charging patients thousands of dollars to run these phony diagnostic studies, doing ultrasound of the vagus nerve, doing ultrasound of the internal jugular vein with and without head turn, doing eye studies, looking at increased pressure. That information isn't changing the treatment plan. It's simply being done because patients will pay for it. And that's not right in medicine, right? If you're running a test on someone, you're running that test to see if it's going to change what you're going to do as the doctor. Christine, I had a hydrodissection. Vagus PRP with you last year was incredibly successful. Almost immediate pain relief, reduction, anxiety, heart rate, probably still need PICL. Well, great, Christine. Thank you for letting me know. That must have been one of the super early ones, right when we were starting to do it, because I think I started doing it more commonly in those autonomic-dominant patients about 6, maybe 8 months ago. But it's great to hear that works so well for you. Thank you for sharing that. Let's see. Again, I'm trying to go through and get things that we haven't talked about already. Marcia, what are your impressions on extradural phylum terminale procedure in Barcelona? Seems the least invasive definitive option for TC. Yeah, Marcia, I'm going to tell you the same thing I tell all patients that bring this up, and that is that occult tethered cord, which is what we're talking about, not tethered cord, right? Tethered cord means that we can see on an MRI that the bottom of the spinal cord is being pulled down by several levels. Occult tethered cord means that the position of the spinal cord is normal. And we then have the Barcelona clinic focusing heavily on the treatment of this occult tethered cord. The problem that I have with that is that one of the things that tends to launch that diagnosis are things like urinary issues and people that have back and pelvic pain. Urinary issues, meaning mild urinary issues that can be seen on urodynamics, are common in patients with back and pelvic pain without occult tethered cord being involved at all. And you can get rid of them by simply doing a caudal epidural and treating those sacral nerve roots. So I would caution any patient that's going to get their cord detethered, because it's a permanent neurologic change with a much higher risk procedure than anything else we can do through injection. So it's a much higher risk procedure than the PICL, for example. So by getting your cord detethered before PICL, you're maximizing your risk. If you want to minimize your risk, you do the least invasive procedure that's the most likely to help. So you treat the CCI and you see if those symptoms go away. They usually do go away. If they don't go away, you can always get detethered. But by putting the detethering first, you're maximizing your chances of having a bad result because you are increasing the risk to yourself personally unnecessarily. So be very, very, very careful with all of that. I know I have probably pissed off permanently the hundreds of patients out there that believe they have a occult tethered cord and need to get it detethered. This seems to be a subset of CCI patients. They're quite vocal. They get quite angry when I bring this stuff up because they are convinced that this is what they need. And there are certainly some that would argue that I shouldn't be pissing any patients off by having opinions like this, right? But that's why I went to medical school. I went to medical school. I've spent thousands of hours studying this area. I've treated thousands of patients with this problem. And so if you can't get an honest opinion out of a guy like me, you're not going to find an honest opinion about this. So not trying to piss any patients off, but I am trying to give a contrarian point of view because I've seen dozens of patients who have had lots of issues with these surgeries. Their CCI has gotten worse. Their symptoms have gotten worse. It's helped these symptoms, but those symptoms much worse. Or they've now got a chronic dural leak that will never be fixed ever again. So I am trying hard here to be as measured as I can in those statements, but it's important for me to get the word out there that probably only about 1 in 10 of the patients that are getting detethered right now, in my opinion, actually need a detethering surgery. And I wish I could pronounce your first name, alias. I PRP posterior, November 14th, started feeling a lot better a month afterward. First 2 to 3 weeks, I'm trying not to feel well again, nausea. Yeah, so again, I don't know exactly what it is you had done. It would be important to let me know, meaning that this is an important thing for patients to understand. Did you have, for instance, simple ligament prolotherapy done with PRP? Was it high-dose PRP, low-dose PRP? What's your age? Do you need high-dose PRP? Was it leukocyte-rich, leukocyte-poor? Were the facet joints injected under ultrasound? Probably not a great way to do it. Were they injected with fluoroscopy with contrast confirmation? Which facet joints? So hard to answer questions like this because there's so much difference between what's called a posterior injection with PRP, what most people would call it, and what we would do. It's hard to answer those kind of questions. Mark, what are your feeling? Exosomes to help remove existing scar tissue from L5-S1 laminectomy. It's a scam. Absolute total scam. Stay away from exosomes. Exosomes are just cellular messages. There's nothing fancy about that. Stem cells release exosomes. PRP releases exosomes. They're just messages. The idea that we could somehow bottle those messages is just pure folly and ridiculousness. And so if someone was telling you they're treating you with exosomes, they don't know enough to not know what it is they're telling you is just a bunch of gobbledygook. So I would run from that provider pretty substantially, meaning that they don't know enough about the basic science behind what they're doing to even understand what exosomes are or why it would make no sense to bottle them and inject them. Lindsay, is PICL unsuccessful somewhat? Absolutely. Again, Lindsay, very, very important. If anyone ever tells you that they're offering a procedure that's 100% effective, run. Don't walk. Run away from that provider. PICL works for about 7 in 10 patients, and that's because we have a very varied patient population. Everything from can't get out of bed, haven't been out of bed for 2 years, to still functional, but I live inside a little box and that tries to control my symptoms. So absolutely, about 3 out of 10 of our bigger patient population don't respond or don't get enough response where they feel like they don't need to move forward in other kinds of treatment. So that means 7 out of 10 do quite well. But very important to realize that this is not magic at all. Rachel, a neurosurgeon, says you can remove the hardware from 9-year-old fusion since bones are now fused. If I have adjacent segment disease, no, yeah, Rachel, it wouldn't make a difference at all because it's the fusion that causes the adjacent segment disease. Anja, your lives and videos have been the greatest help. Thank you so much. Thank you, Anja, for recognizing that. And guys, I think we're starting to, I'll throw that one up. Lisa, thank you for all you do for everyone. You and your practice are absolute angels. Well, thank you, Lisa. Okay, guys, so we are about officially 20 minutes over. So I'm going to wrap this up for this week. I will be back next week with another Facebook Live. Again, if you get a chance, go on Reddit and look up r/PICL, r/PICL, and join that Reddit group because it's a growing community of patients that are looking for answers, just like the ones you got here today, but you can get them in writing and we can have documentation then that patients can go back and search so that they can get answers in seconds. So that's really the goal of that. And then Christy, excellent topic. Thank you, Christy. So again, have a wonderful week. I will continue doing what I'm doing. And I will be back next week with another interesting Facebook Live. Again, check out that Reddit page. Thank you.